Good morning and welcome to MTSO. It's so good to see all of you here. I'm going to give some introductions this morning, some information, and hopefully you won't be too bored of me talking by the time the real speakers get up here to talk. Part of my role here at the seminary is leading the Theological Commons initiative, which is the program that brings events like this, bridging what we're doing here at the seminary and speaking about issues that we feel are relevant with the community and the wider public. So again, thank you for being here. I want to give you some logistics just so you know where things are. Restrooms are right off the lobby where you came in. We'll spend the morning in this room. We'll take a short break after our keynote speakers before our panel and then head up the hill to lunch. It is up the hill, so if you would like to drive, there's a parking lot behind that building. And then most of the breakout sessions this afternoon are just across the courtyard here in a building called Galt Hall. Don't worry, everyone around here is friendly. And if this is your first time, well, you better be on your best behavior. No. If this is your first time to campus, we will make sure you get where you need to be. And of course, with every event, there are many people a part of the planning and making things happen. So I want to thank everyone in our event staff, our tech staff, maintenance, our chefs up the hill. You'll get to enjoy their gifts shortly. And all of our speakers who have come, some from quite a distance, some from down the road, to be with us today. So we're grateful for them. We also have a table in the lobby of some representatives from various disability ministry advocacy groups or providers, and I think they're in the room, so I'll just have you wave, and if you have questions for them, you can talk to them throughout the day or at lunch at the ending session. Beth Kuntz-Wineland is here from Bittersweet Farms, which is up in White House, Ohio, and also Lima. And Rich Schultze is from the UMC Disability Ministries organization serving West Ohio Conference. And there are a couple of us here with the AdNet Disabilities Network. There's some information out there on the table, and I see Tracy walking in right now. She'll be on the panel. You can ask Tracy or I things about AdNet. Feel free to take that information with you today as you go. So let me introduce our two keynote speakers for this morning. Two guys that have known the area of disability for pretty much the entirety of their careers or their personal lives. And I'll start with John Martin. John Martin was appointed as director of the Ohio Department of Mental Retardation and Developmental Disabilities in January of 2007. As many of you probably know, the department was renamed to the Ohio Department of Developmental Disabilities in 2009, following the efforts of many of Ohio's self-advocates. In 2011, Governor John Kasich reappointed Director Martin to continue serving as the director of DODD. Martin has emphasized leadership transformation in several areas for the department, including increased collaboration with stakeholders, upgrading technology infrastructure, and making data-driven decisions to help better align resources and programs for long-term sustainability. He has led several core initiatives, such as creating more opportunities for individuals with developmental disabilities to live and work within their communities, developing the Positive Culture Initiative, supporting shared services and collaboration models among county boards across the state, and consolidating all DD programs under the Department of Developmental Disabilities to reduce confusion for those who use the services. That's not a short list, John. Thank you for your work. John came to the department from the Toledo area and knows the disability community firsthand, not only as the father of a young son with disabilities, but also as the former executive director of Sunshine Incorporated of Northwest Ohio since 1984, which was a nonprofit organization with Mennonite ties serving people with developmental disabilities and their families. In 1995, John also became the first executive director of MRDD Solutions, which is a for-profit subsidiary of Sunshine that provides software to more than 100 agencies in 18 states. I have been pleased to get to know John over the last couple of years. He is well respected in his work, and we are very grateful that you could be with us this morning, John. He's going to give us this morning a snapshot of what's happening in our state. And when he gets done doing that, Bill will immediately follow him. before time for question and answers for us. So for those of you that have already heard me introduce Bill, I just don't know how to shorten this introduction for the rest of you who haven't been here. He's currently the director of the Summer Institute on Theology and Disability, as well as the new collaborative on faith and disability, which links a number of university centers of excellence in developmental disabilities who address spirituality through several initiatives. He was formerly the Director of Community and Congregational Supports at the Elizabeth Boggs Center on Developmental Disabilities in New Jersey. And just so you know, University Centers of Excellence, we do have one in Columbus at the Neisinger Center at Ohio State, and Tom Fish is back here representing them today. We'll give a breakout session later. Bill's primary areas of experience and expertise are spiritual and faith-based supports with people with disabilities, training for clergy, chaplains, seminarians, and community staff, aging and end-of-life and grief issues, and intellectual and developmental disabilities, cultural competence, and community building. He has previously served as the president for the American Association of Intellectual and Developmental Disabilities, and he has the ability to speak multiple languages, from theology and church to medical and provider, and of course to self-advocates and with families and individuals. As a writer and editor, he has edited newsletters and several books, written articles and chapters, is the associate editor of the Journal of Religion, Disability, and Health, and his new book, Spirituality and Disability, Recovering Wholeness, has recently been released, and we're pleased to be offering that book out in the lobby at a discounted price throughout the day. Bill and his wife, Beverly Gaventa, moved to Waco, Texas, where she is now the professor of New Testament interpretation at Baylor, and their son and daughter-in-law are both clergy in Austin, making also Bill the proud grandfather of Charlie. So for those of you that were in chapel yesterday or in the lecture last night or maybe at the lecture at Ohio State yesterday, you have had a taste of the experience and insight that Bill brings and also how busy we've kept him while he's been in Ohio. So as a person who has long learned from Bill Gaventa, I am very pleased that he could be with us leading these conversations and that he can be in conversation with all of you over this day. So before they speak, Joni Kalem is going to lead us in just an opening number. Joni is a parent, a teacher, and a disability advocate, and a songwriter, and she will be providing some music for us today as well as a breakout session later. So thank you all again for being here, and Joni. Just in case anybody has hearing issues, I will put on the microphone. I am of the Jewish faith, and in Judaism, the first thing we do when we wake up in the morning is to say a prayer of thank you. Thank you for waking up. Thank you for everything around us. So this is a thank you song. It's also an echo song. So I'm hoping that you will be my echo. I'm hoping that you will let your voices and your bodies and your hearts wake up, because I'm saying thank you to these people that are following me. So get ready to echo. It comes up fast, okay? When awake in the morning, at the dawn of day, thank you, thank you, what I say, we never
I appreciate the opportunity to spend some time with you all this morning. I appreciate the courage of pairing a bureaucrat with a theologian. So that's kind of nice. When I'm done, he can clean up all of the messiness of the bureaucracy and what it means. So what my goal is in the whatever it is, 45, 50 minutes that I'll be chatting with you is to give you an overview of the Ohio system, which I think was what I was asked to do. And what you're seeing, although this is a little modified version, I've been doing what I've been doing now here at the state for almost 12 years. And so I'll be leaving when the governor leaves in a number of months. And so I've been issuing kind of some challenges to the field as what I see coming on the horizon in some areas. And you all will be spared the lecture that I use from these slides to take off on the county boards, and the lecture to the providers and lectures to others. So this will be more of a, I call it a clean presentation. And I hope I don't get too much in the woods. I know there's varying degrees of probably understanding of our system. And what I want to, we are heavily dependent upon Medicaid. And that's common of every DD system nationally. And so to kind of understand what's going on in our system, I wanted to explain a little bit about Medicaid. And so how Medicaid works is for every dollar that is spent in our system, about 37 cents is put up by the state or the county boards, and about 63% cents by the federal government. And that match, what it's called, that match is determined by the wealth of the state. So if you lived in a very poor state like Louisiana, I think they only put in about 25 cents in the dollar. If you lived in a wealthy state, I think Alaska's about 50, although they're now poor. They claim they're poor anyway. And I don't know, Bill, what Texas is, what their percentage is. I'm guessing it's probably lower than Ohio, but I don't know that. And so our system is complicated then by we don't just use state dollars to match, but we also use county dollars to match. And Ohio as a state is very unique. There are only 17 states in the United States that collect any local dollars or use any local dollars in their DD system. Only 17 states. And of all of the dollars collected from those 17 states, over half of that's collected in Ohio. So we collect over $1 billion in local revenue that you Ohio citizens vote on in your individual counties. So our system is a local system administered by local boards. Sometimes they listen to us, sometimes they don't, but they're independent by local boards. And the other unique thing about Ohio is there are only 4 state departments nationally where the person in my position reports directly to the governor. So we're one of only 4 states that the DD agency is a cabinet level position that is independent of any other part of the state bureaucracy. So a little bit about Medicaid then. In Ohio, we spend $2.8 billion a year on folks with developmental disabilities through the Medicaid program. And where we spend that, so I'm going to go over kind of the major service platforms that we have, because that impacts kind of a lot of stuff that's going on. And so Medicaid came into the states kind of in the late 60s, and it came in an interesting way. There was a legislator from Texas who had a daughter with developmental disabilities, and he knew that if she went into a nursing home, she could get some services there, and there were some Medicaid dollars in the nursing homes, and he wanted the same service available to folks with developmental disabilities. So on a bill that was designed or was being put in place to ship bodies back from Vietnam, he put a one-sentence rider that allowed the use of federal funds for folks with developmental disability. And hence was born the Intermediate Care Facility Program, what we call the ICF program. Good example of federal planning. So something that was never debated, never recognized, it was there, a single sentence. Today we spend billions and billions of dollars nationally on. And so what happened prior to that in Ohio and other states, all of the programs were funded by state grant dollars. So Ohio ran 12 large institutions. They were called state developmental centers. There were 10,000 folks living in those centers. In addition, there were a number of private, and a number of our private early facilities had their origins in church-related agencies. So you had Luther Home of Mercy connected with the Lutherans, and Fellinghome with the Lutherans. You had St. Joe's connected with the Catholics. You had Rosemary Center connected with the Catholics. Flat Rock connected with the Methodists. And so there were a number, and then Sunshine, where I was at, connected with the Mennonites. These were all 100% state-funded at the time, as were all programs. Well, suddenly the bureaucrats realized if we can convert this to Medicaid, suddenly all of the money that we're using 100% of state dollars for, we can now match those with federal funds. Manna from heaven rained down upon. And so they forced, all the state centers switched to Medicaid, all of the private facilities had to switch to Medicaid, and what happened is that freed up a bunch of state dollars, which were then reinvested in the community movement that really started here in Ohio in the 70s and into the 80s. There were a lot of group home development, et cetera, that occurred through that infusion of federal dollars. So what happened then in the Reagan administration, states started to say, man, these ICF regulations, nobody likes bureaucratic regulations. And so states started to say to the feds, hey, these regulations are costing a ton of money. So there are 435 regulations, bittersweet is here, in the ICF program. Okay, 435 federal regulations you have to comply with. And so states went to the feds and they said, hey, if we didn't have to follow those regs, life would be better and cheaper. And if you would just waive those ICF regulations, it would be a lot better for people and a lot cheaper. So that's what the waiver program is. You hear a lot about Medicaid waivers. The waiver means it's a waiver of those ICF, those federal regulations. And the Fed said to the states, all you got to do, we got rid of those 435, you now just have to follow 5 things. And the most important, I mean, they're pretty simple. You got to maintain health and safety. You have to have statewide-ness. But one of the keys was something that because you have reduced those regulations, then the way of ensuring health and safety is you give the person who has the waiver the power to choose who's going to provide that service. So in the ICF program, the state funds the bed. And if you're in that program and you don't like it, you're out of luck, okay? I mean, you can leave, you can go to another one, you can complain to the director, whatever. But the bottom line is that in that program, the bed is funded. In the waiver program, then the individual is funded, and the money is attached to them. And so the idea was that if we give the control to the families and we give the control to the individual, if the services are not good, I can go find another provider. I'm not held hostage in the program. And so hence, you saw, starting in the 80s, the massive expansion of the waiver program across the United States. So, and this kind of gives you an idea here in Ohio of the money we spend. So we have state-operated facilities. We have 8 of those, and we serve 650 folks in those facilities now. And those are the most complex people in our system. So we do a lot of short-term services. So, for example, if somebody has really complex issues, usually dual diagnosis, we do a lot of 90-day, 180-day short-term stays. We have intensive services that we provide, and then we have resource coordinators to then try to find them places out in the community once we have stabilized those issues. So again, if you know somebody or connected with somebody with really complex issues and can't solve those, sometimes our state-operated centers are an option. We rarely use that for permanent placement. The only people who are in there permanently, for the most part, are people that are there because they're in trouble with the law, and so they're there instead of prison. And others are there for some probate reason. The probate judges put them in, or they have been with us 30 years, and that's home, and their families are choosing to remain there. So, and then we have the large privately operated ICF program. We have about 430 facilities that folks live in there. And again, you would know the names of a lot of those. A lot of the traditional church agencies were state funded and then converted to ICF. So all the names that I mentioned earlier are funded through that. And then a lot of them have diversified into the Medicaid waiver program. So you can see all of our growth there. The individual options waiver is our complex care waiver. It has all the services in it. Level 1 and self are more to support folks who are living at home with mom and dad who don't have as many needs, and those waivers help support them in those situations. And then everybody that is in one of those facilities gets their health insurance covered through the Medicaid card for the most part. And so of the people in those two programs, it costs the state about $500 million a year for their health insurance. And part is a lot of the folks have some really complex issues. Now, if you're sitting in your seat, and I'm probably spending too much time on this, but and you're a good math major, you would say, wow, 45,000 people for $2.8 billion. You know, you would quickly realize that's about 60-some thousand per person in the Medicaid program. So it's a lot of money. And here's just what our system looks. I'll skip that. So the major themes, which are going to be connected to some of the stuff that we talk about. And one is that litigation has driven our field over the years. And, there was the first major case in Willowbrook, New York, kind of started it all. Moved to Pennsylvania. We had the Pennhurst case where the state of Pennsylvania was sued. And we have about 30 active, what are called lawsuits, Olmstead lawsuits. The name comes out of Georgia, where two ladies living in a mental health facility wanted to leave and couldn't. And they sued the state of Georgia. It expanded, states entered in, and it's kind of a landmark. It's called Olmstead. And so these Olmstead lawsuits have become fairly common. We avoided them, so one of my claims to fame and my legacy will be that shortly after the governor announced he was running for president, I got him sued. And he was named, along with myself and the Medicaid director, in an Olmstead lawsuit. Just saying, he was very appreciative. So I'm going to talk a little bit about workforce, and so litigation then drives us a bit in Ohio, as it does virtually every state. Either the fear of litigation, Texas has had its share of litigation. I could go on, but I won't. I'm already going on. So I want to then talk about workforce. I want to talk about the Inspector General and their involvement in our state and other states. You're going to get some political commentary both under workforce and tax cuts and a healthy economy. I think the impact of that, I think, is going to be devastating in the next 5 years in this field. So I'll make the system complexity. I'll go over that quickly. One of the things that keeps me up at night is number 6, along with number 2. Talk about complex youth. We are seeing just a real increase in folks, often with autism and some other complications. that our system is just struggling mightily to manage. And then what do people think who are served in our system? So, working through those quickly, litigation relate to, and you probably can't see the slide, but litigation typically relates to if somebody thinks you're spending too much money in the ICF program, the Intermediate Care Facility Program. So that's viewed as an institution, institutional care. You're taking away the rights of people. They don't have the ability to leave if they want to. It's often in that area. Now, we have argued, and so these are national trends and state trends. The state trends are the dark lines. The dotted trends are the national lines. And so you can see dollars spent on intermediate care facilities compared to waiver facilities. So even though we feel we are doing well, 3 outside law firms, one from Massachusetts, one from Michigan, and one from Washington, D.C., joined Disability Rights Ohio here to sue myself, the governor, Medicaid director, for running an institutional system. So we have been battling that. It was one of the things I had hoped to get finished before I leave, and I don't think now we will. But again, it's all about pushing the state, more waivers, less institutions, less institutions. So again, if you have questions about that, assuming I don't burn up all the time, would be glad to talk about it. Workforce then. Here's some things, as any of you know, if you are families trying to get staff, or if you're an agency trying to get staff, workforce is a huge, huge issue. And nationally, 1 of 4 workers is an immigrant. 1 of 4 workers in our system are immigrants. My mom is in an Alzheimer's care center. Virtually everybody who works with her is African or Haitian. In the state of Massachusetts, there are 4,000 workers in their nursing homes who are Haitian, and virtually everyone, if Trump ends that extension they put on, virtually every one of those 4,000 will be deported back to Haiti. There are already 7,000 nursing home vacancies for staff in the state of Massachusetts. So again, this issue of immigration restrictions is huge when we look at the workforce crisis we're facing. Unemployment rates are very low. We're seeing wage pressures increase in terms of what Walmart's doing and McDonald's doing, etc. And so lots of pressure on that. And then some of us are getting older, and we may need some care. And so this issue of demographics, issue of immigration, an economy with virtually full employment, workforce is a huge, huge issue now and into the future. We've had a number of initiatives. We've tried to get more money to direct care staff. The governor was kind enough to give us a wonderful increase in 16 and 17, 6% for direct service staff. In this budget, we were able to get, so we'll now pay $2.50, almost $2.50 more an hour if somebody is serving somebody with very complex needs. We also were the first state to get into place something the feds allow, which is to pay more if somebody has some longevity and some education. So starting in July 1, any direct service staff who goes on our online, and takes 60 hours of training, it's competency-based, and has 2 years of experience, we will pay that agency $1.50 an hour more so that direct service staff can get $1 an hour more. So again, it's the first attempt. It's the first time we think this has been tried in the U.S. And again, we've also done a few other things to try to deal with that workforce initiatives. One of the interesting things that we're working on, and something with, I would suggest maybe some theological connections, a graduate of Goshen College, her name is Ruby Payne, wrote a book called Bridges Out of Poverty, if any of you have read that. It came out, I don't know, quite a number of years ago. But part of it is the recognition that people who are raised in poverty and live in poverty make decisions in different ways than what some of us in the middle class make decisions. And so we have a workforce that is people who are living in poverty for the most part. A lot of our folks are. And so what Bridges Out of Poverty does is it trains the management staff in a whole new way of thinking about how do your personnel policies need to work, how do you connect with people who have lived in poverty to support them. And it's kind of neat. Sunshine was involved in a pilot project in this, and in implementing it, saw their turnover decrease to the point where they had to hire 50 less staff, and the money they saved from that, they were able to give a 3% increase to the staff who were there. And again, it does things like creates so that staff in poverty don't have to go to payday lenders, which for some reason our legislature has not cleaned up here in Ohio. Strangely, anyway, I'm sorry, I'm not going to divert. I have a problem with tangential, as some of you know. But anyway, so they have a deal with the credit union where they will do a loan. Somebody's car breaks down, they don't have the money to get it fixed. You can get a loan and then pay it back, no interest, through payroll deduction. And so they've established it. They call them some kind of loans. Anyway, it's a neat thing that we as a department are going to be doing a bunch of grants in that to try to encourage more providers to take advantage of that. The other thing that we are doing is technology. I burned out the first translator, so sorry. And that is, again, we were one of the first states to get technology in our Medicaid waiver program, and the governor has been very supportive. He gave us a $500,000 grant, which we gave to Mark Tassi at Nysonger. He runs the technology, or helps us with that. But what we're looking at is with the workforce shortages, how do you use technology to support people? And I think, I won't go into detail, it has a lot of opportunities for supports as well, I think, within congregations as ways to use technology to support some congregational members who, who may struggle. But just an example how some of the uses we've seen, we had a young lady who had extremely aggressive behavior. She attacked staff, herself. Our technical term is elopement. She ran away. Extreme issues. And they had trouble recruiting staff in that program. And somebody said, hey, why don't we try technology? And the person in charge of the program and the technology company that does it said, oh, no way, that's not what our technology's for. It's more for example, there's a lady in Licking County has severe seizures. She didn't want, the alternative to technology was staff sitting watching her 24 hours a day, so she had a seizure, they could help her. So instead of that, we put sensors in the house, so whenever she falls, the sensors click on a camera, can check in, are you okay, do you need anything? If you need 911, you can send 911. She and her family are happy as clams because they're not always hassling with staff. She has much greater independence, and it's saving the state about $60,000 a year. Well, anyway, back to the case of the individual that I was starting to mention. So the company said, no, we do more of this kind of stuff. We don't do that. But the interesting thing is they put it in the house, and when staff weren't there, her behaviors, dropped. When staff weren't there, she stopped running away. And the interesting thing was with this technology, the remote technology, where you can have a presence through cameras, and one person can be connected with 6 different individuals in 6 different places anywhere in the state. And if there are issues, you can check in or see, or if there's an emergency, you can send somebody in. Anyway, interestingly enough, so her cost, the state was paying $150,000 a year for her care. She was very unhappy. Her family was unhappy. With the use of technology, the costs have decreased to $40,000 a year from $140,000. She's happy, and not that long ago, they took all the technology out because she doesn't need that anymore, and she's virtually independent. So it's one of the initiatives. We have a huge technology conference coming up, sponsored by the department and Nysonger, and we think it's one of the kind of game changers long term. I mean, we always will need direct service staff. This is not about eliminating, but we think combined with other things, it helps us deal with the workforce shortage. Here's what we pay in Ohio. You can see our average hourly rate, what the turnover rate is, 50%. You know, imagine, you know, having to depend on somebody else for all of your needs, and the turnover rate is 50%. And that is very common with national figures. It's, Ohio's about in the middle of the game there. But workforce is huge, 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 huge. So then, the Inspector General, government bureaucrats always create problems, you know, and there's an old saying about what flows downstream that I won't mention in the seminary walls, but it has really downstream effects. And in this case, in Connecticut, a very powerful senator who was very close to the nursing home industry and other industries in that ICF category, if you think back a number of slides, felt that there wasn't adequate supervision in these community programs. And so he sent in, through a thing, the Inspector General, and the Inspector General went into Connecticut and then moved to Massachusetts and then to Maine and then to Alaska. I think they're now in Pennsylvania. And what they do is they go into your medical care, your Medicaid claims data, okay? So as I mentioned, everybody has insurance through the Medicaid program. And so the Inspector General went into those Medicaid claims, okay? And in the Medicaid claims, they looked for injuries, okay? So they found a bunch of injuries. Then they went to the state's DD agency, the equivalent of our agency, but in Connecticut, and they said, okay, you have an incident reporting system. So in Ohio, we call it MUI, Major Unusual Incident. Anybody sees anything suspicious, any allegations of abuse and neglect, you report it to our Major Unusual Incident reporting system. We then have 200 people around the state, most of them county board employees, who will go in and investigate those major unusual incidents and see, did abuse occur, did neglect occur, you know, what was the situation, and then we look to remedy that. Again, that's the state's incident reporting system. So what they did is they looked at the Medicaid claims, the health care claims, and then they went into the MUI and they said, oh, there are massive numbers of potential abuse. We found all these claims of broken bones and stuff in the health care data, and we found no investigations and no major unusual incidents in your MUI system. And so there were 5 straight days of negative articles in the newspapers in Connecticut first, slamming the community system, saying it was unsafe, saying that state was not overseeing, was not adequately taking care of abuse, that abuse was rampant. And then, they went to Massachusetts, did the exact same thing. They went to Maine, they did the exact same thing. Huge numbers of negative stories. And so what has happened then, so what do bureaucracies do when they think, you know, it's massive, potential massive new regulations. So we in Ohio have tried to get out ahead of this, and we actually are working with CMS. We're one of 5 states working with them to look at how we marry Medicaid claims to the incident reports. And we took a 3-month period of time, and we went into in the Medicaid claims. We have access to the Medicaid claims. So we looked at how many broken bones occurred in a 3-month period. And we found that there were not 75 or 77. We then went into our incident reporting system to see how many of these did we investigate. And we found that we did all but 11. So there were 11 we didn't investigate. And so then we dug deeper to say, well, why didn't we investigate? Well, the reason is, with the waiver program, a fair amount of our waivers are used by families in their own home. And if there is no paid staff present, if it's just mom and dad, and there is an incident, families are not required reporters. So they are not supposed to report, nor are they required to report into our MUI system. And quite frankly, we found that in 10 of the 11. They were not with paid staff when it occurred. In communicating with the directors from Connecticut and the other states under scrutiny, that's what happened a lot in their system, but they didn't know. I mean, they didn't have the ability to keep up with the federal investigators to look in, to see the issues, and to be able to respond to some of that. And so we're working with CMS. They put out a bunch of guidelines, which our concern is it'll put a lot more restrictions on providers, a lot more oversight responsibility to states, when we think in part the systems are really working pretty good, and a whole bunch more regulations just really create more problems than they solve. The other thing I won't go into unless anybody later would have a question, which hopefully you don't, is they also found fraud in what they called home care, and so they're now requiring states to do this electronic verification. It's what EVV stands for. And so, so that a home care worker going into somebody's home, they feel there's a lot of fraud there. The feds feel there's a lot of fraud there. Somebody says, yeah, I worked there for 10 hours. Really, they worked there for 4 hours. They bill the state for 10, not 4. And so, fraud is rampant. That's always the view. So to solve it, you're going to have to call in. Everybody is going to have to call in. There has to be a record. You're going to have to reconcile it. It is a mess on the horizon. We're supposed to be implemented by the end of the year. Anyway, thank you, Inspector General. So the only thing to say, the one thing that's been real beneficial to us, and I do want to say we have been doing a lot of trend analysis looking at, if we have shortages in staff, what should we be seeing in our incident reporting systems and in incidents? What injuries would you guess might be increasing? Are we seeing increases in abuse and neglect? What are we seeing? And so we're trying to proactively look at the system, look at what we think some of the weaknesses may be, and saying, is that showing up anywhere in our systems? And if it is, what might we need to do to respond to that? So kind of doing a lot of work in that area, but in general, I feel providers are really doing a good job or not seeing alarming trends. And I will zip through these quickly, but an increasing amount of attention we're paying as we started looking at Medicaid claims in relation to this project I just mentioned. We started to see how folks with disabilities differ in medical issues than the general public. And so while you can't see it there, and I'm semi-colorblind, but the general population is in whatever the light green kind of is, and then folks with DD are in the purple. And so we kind of look at, how do folks with disabilities differ from the general population? And we also look at unscheduled hospitalizations. Again, this is too much in the weeds. I'm going to zip through. And then we looked at, so what are the most expensive? What do we spend the most money on? And can we start working with providers and families and advocates? Are there ways that we could prevent? Because if we're spending a bunch of money, you don't have a good life, right? If medical care is costing a lot. And one of the things that we're seeing is incredible rates of septicemia, blood poisoning. And if you think about that, there are some logical explanations for it. But there's our population compared to the general population. And again, very, very high. So what we're doing is we're digging in. We're looking at agencies where we see a lot of septicemia. And you could probably guess where we might see those trends. And then we're sending staff out to kind of work with them to say, you know, are there ways that we could work at preventing this, making their lives better, etc. The other one that we're focused on is mental health. Again, I learned early on, a key to presentation is make your slides so small people can't read them, and then you're not held accountable for any data you present. I'm sure, Bill, you use that all the time. It's a great theological tool. Anyway, but this is emergency room visits for mental health issues. And these are folks we serve in our system. And you can see we had 5,000 ER visits for mental health issues. And the ER room is not a good place to get treatment for mental health issues. This is of a huge concern to us. And you can see how bogus it is, if you know a little bit about the field and the claims, that the number one is depression. Well, you really don't go to emergency rooms for depression. I mean, most people don't. You might if you have suicide. But of all of the codes for mental health, guess which one pays the most? Depression. So if if an emergency room doc is looking at what do I punch in the 30 minutes or 15 or 5 minutes I spend, for some reason depression gets punched in if they don't know what else to do. And so we have been working with a group of psychiatrists to look at, as well as looking at areas of the state, again, looking at providers, and again, not from a punitive perspective, but, you know, what are we seeing, what can we do to help, how can we decrease? And so we have a number of initiatives coming out that kind of connect with that. The one thing we're not seeing is much drug issues in our system. You can see only, you know, the 45,000 folks, 165 went to an emergency room for drug overdose issues. So again, not a huge sort of percentage. Moving along quickly, what time am I supposed to be done, Kev? 10 minutes? Okay. I spent some time talking about Medicaid in the beginning and the amount of Medicaid dollars. Because when you hear about entitlement reform, that's Medicaid. It's Medicaid and Medicare. And so we gave tax cuts in a healthy economy. And as I say to my friends, I have friends who are both Republicans and Democrats. When I say to my Republican friends, you know, I know you guys don't care about deficits now, but as soon as there's a Democratic president, you're going to care. And there is going to be huge noise because of the explosion of deficits. And when you give tax cuts in a healthy economy, you don't reap any benefits of additional revenue. I mean, the economy was already boiling healthy. So what we've done is we've created huge deficits at a time when revenue should be fairly good because the economy is there. And you know, we've got road problems, you know, they claim the military is weak, all of that stuff. So we fight with those other parts of the government for money. And the fact we depend so much on entitlements and so much on Medicaid that, you know, when they talk about the deficits, they're going after entitlement reform, and Medicaid will be at the front of that list. And so it is a huge concern. I think it's going to hasten, and if you have questions on, I think, block grants, managed care is already coming in. These are other terms for how do we do more with less money. And then these show all of our charts. I love charts, I love data. It's one of my obsessions, weaknesses. But Ohio spends a lot of money per population. So the red is Ohio in all these. We're the third state in the nation in terms of the amount of money we spend, and this then adjusts for population. So you're comparing all states, and you can guess where Texas is. Fourth from the bottom. On most lists. So anyway, and you know, spending a lot of money doesn't mean it's, you know, any better. I'll just say that. And so we kind of look. I just show to our field that, hey, if they're going to cut costs, where's the excess cost in Ohio? It's not in the ICF program. That's how we compare to other states per person cost. It's not in our state-run centers. That's how we compare to other states and their state-run centers cost. It's not in our waiver program. It's where we rank in terms of other states, in terms of how much we spend per person per waiver. The only area we're a little high, which is why we're focusing on it, is medical care. And this is the cost of the card services for folks. So we've got some initiatives going, as I mentioned, in that area. But, and again, I'm sorry. Yeah, that's how many people. This talks about the number we serve. I got off track. So if you compare the number of people who live in a state and the number who have waivers, you can see that we do a pretty good job in terms of penetration in the waiver program. And then in terms of cost, this is a high area, and that's the card. We have a lot of, wrapping up, you don't need to know about that. We're trying to simplify our system. We have phenomenal complexity that's adding cost. We're trying to simplify our billing system. I mentioned how much we depend on county boards for money. The weakness at the state is they're not required to submit to us any cost projections, etc. We don't know if a county is in financial problem or not. We've had to support 4 counties in the last 2 years as their projections have not necessarily been on target. And the whole reliance on county board system, the fact they're not able to pass levies in a lot of counties now, this is one that, again, it's kind of a concern. And then, as I mentioned, complex youth. We get a lot of calls. I had 2 on my email this morning. And we have 2 pilot efforts that we are setting up. We've funded 8 collaborative respite projects, again, hoping to focus on folks with complex behaviors. We're doing a technical assistance grant to try to support providers who have interest in complex youth. Why that is increasing, that would be another long discussion with a lot of different opinions. And I just conclude with then, we do something called the National Core Indicators, where we do a representative sample of folks and we say, what do you think about our system? And then we compare to other states. So blue is Ohio and red is the other states. So again, in general, we find we're doing a better job on employment than other states. This one, people seem to like their home, like where they are. Employment, we feel Ohio's doing a pretty decent job. People like the jobs they have. This is kind of interesting. It gives us an ability to keep an eye on the staff turnover, staff issues, but yet you can see that 90% of the families or the individuals report that staff are respectful, that about 70%, a little better than the national norm, can request to change staff if they aren't happy. Staff show up and leave when they're supposed to. Again, huge issue in staff shortage times. Have friends. We all want friends. Again, a role that I think faith communities can do a lot of help with. They can go out in the community integration. Always has a way to get to where they want to go when they need to. Again, very high percentages feel they have a good life. Again, about 90% of the folks report feeling they have a good life. This is one we've seen improvements on, and that's feeling lonely. Huge issue, right? All of us, like friends, don't want to feel lonely. Again, our numbers are down in this area, which means providers, communities, whatever, are doing a pretty good job connecting with people. And do you have a place to go when you're afraid or need help? So anyway, I think that's the end. I tried to give kind of an overview. Hopefully it wasn't maybe just in some small way helpful. But I think as you think as faith communities and people of faith, I think the role of advocating with the government is going to become critical in a lot of areas. You can see the impact some of the current decisions that are being made nationally are going to have on our field. And just with the scarcity, potential scarcity going forward, the role congregations are going to have in supporting families of folks who have children with disabilities and the folks with disabilities themselves. So Thank you. I apologize if I went a little long. Bill, you're up. Take it.
That's my grandson. In case you're wondering. All right. So last night, John, what I did was talk to faith communities and say, what do we preach? How do we work? What are our core mission values? And then how does disability fit into that? Not trying to change the conversation from thinking you've got to change your core mission or to do something special or extra or different. And so this morning is kind of trying to say the same thing to service systems in terms of practicing what service systems preach and what we talk about in our values. But before I get into that, I want to just make a couple of theological/spiritual comments on what you just said, and just to emphasize them with an exclamation mark in that system. One was the huge point about the waiver giving more control to individuals and families. And for the most part, that's a gradual growing trend, but it doesn't happen all the time. The system can say we believe in self-determination and person-centered, but it's still the voice of families and individuals, and others still really have a hard time holding sway over the vast number of professionals. Litigation drives the field. Rights have driven the field ever since the 1960s. And like we said yesterday, in a system that's based on driving the field by rights in order to enable community inclusion, rights will get you a space, but it won't get you relationships. It won't get you relationships. It'll get you a space. It'll carve a space. It says you have a right to be there, but it's not going to get you relationships. And the other thing it does for direct care workers and providers is when litigation or inspections or compliance with regs drives the field, you also then have a fear-driven field. That there's so much energy being focused on fear about what could happen and doing something wrong than there is then energy for what the positive things that could happen. I had a quote, a guy said to me once, a guy who was a chaplain in California in one of the old institutions there, said to me one year, this is 25 years ago, he moved into quality assurance, which I think is a great place for people who are pastoral care folks, and there's some really interesting people doing some work. One of my best friends, Hans Reinders, who's a theologian and ethicist in the Holland, has been doing a whole new way of looking at quality on the basis of relationship, not on other kinds of objective kinds of things. But this chaplain in California said, out of his work on quality, said, since we don't know how to enhance commitment of direct care of staff, we rely on compliance. If we don't know how to enhance people's commitment, sense of call, mission, commitment to their jobs in a kind of way that we talk about in ministry, the system ends up relying upon compliance. And one of the real ironies in the system is that you have certain political parties who believe in less government, but who are scared to death that somebody's defrauding somebody somewhere, that they end up passing rules and regulations that make governments even more onerous and end up costing people more and doing more paperwork. You would think Texas, with all of its, quote, values of free and independent choice and stuff like that, would be sort of fairly open and free. Well, I tell you, I have never seen a red tape, bogged down bureaucracy anywhere as bad as I've seen in Texas. I mean, it's like you've got to get 10 approvals before you take a step. And so that's a real paradox, and it ends up costing money in this day when supposedly things are being saved. And the other thing, the hospital visit things you're talking about, I'm really glad you're looking at that. But the pastoral care, theological question about this, and human care is that for people with complex needs, hospitals are dangerous places. They are for many regular folks, but they're dangerous places. Because what happens there, we talk about the way attitudes impact people coming to congregations who have complex needs. People run directly into attitudes in hospitals. So the question goes in, and somebody who's got really complex needs, and the question is they've got an illness or they're sick, and what happens with some hospitals and some hospital staffs is they see quality of life and disability rather than the illness or the disease. And that's where you really need then people who are with people to be able to help tell the medical staff who this person is and what their story is and how valuable that person might be to hundreds of people, especially these days when you've got more and more community friends in some places. This is not just this one severely disabled person in the hospital. This is a person who's got a network of staff or friends or people of connections at times. And so if you can't help them see the person. There was a faith-based agency in New Jersey that tried to figure out. There are two people that I know doing creative things about that. Elizabeth Perkins in Florida has created a little 8-page, 10-page thing called a healthcare passport, which is like an individual, person-centered, this is who I am kind of thing, identifying for somebody to talk about who they are, to leave on the bedside for nurses and doctors. It doesn't use medical terms, but talks about who this person is if they can't talk. This Eastern Christian Children's Retreat in New Jersey did this another way, is by putting information about characteristics and things that people loved or what they didn't like and stuff, and wrote them on a helium balloon and tied it to the end of the bed so that staff who came in could see that in case there weren't people there with them. Again, just to try to help people see the person behind the disability labels. And so those are just some kind of quick comments to some of the kinds of things. So let me come at this. I've worked, as I said last night, on the faith side a lot, and I've worked a lot on the secular side, the public side. Taxes have paid a lot of my salary over the years, and I've worked on a number of projects, including for about 10 years in New Jersey, projects trying to help direct care support staff, and I couldn't agree more with you about that, because the numbers of people who are immigrants in New Jersey who do the direct care is just astounding. And many of them, the thing about it is many of them are incredibly good people, but we rely upon them to help people find community and get more connected to the community, but you're also then relying on people who that's their journey as well, trying to find their own sense of place in the community, and so they may feel like outsiders as well. So if you're working through a church with people in a group home and they've got staff who are coming from other countries or from this country who are going to be the working poor, as John says, I mean, almost every direct care person that I knew in New Jersey worked more than one job just simply to get by. And then you have politicians saying these are lazy folks and don't work, which just drives me up the wall. But any kind of ministry to people living in group homes has got to include a sense of ministry to the staff there as well. Just like you would talk about ministry to a family, it would be ministry to the parents as well as the kids. So if you see staff, get to know those staff who are there too, because if they feel welcomed and they feel like they're partners with you and you have some ways to kind of help them be connected to the community, you're going to have a whole lot better chance at having an effective kind of building relationships with people in homes. So, the system, the word these days is person-centered, family-centered, person-centered planning, person-centered. Starting with an individual, with somebody, who we are. The question of identity. Who am I? Who am I? And that's the big question is, in the world of disability, when people try to say, I'm a person, let's use person first language, let's get away from labels. Don't, ban the label, the kind of no more use of retardation and all those kinds of things. But we still have a hard time getting beyond the label. Has got such a powerful kind of connotation for lots of people. One of the pioneers in this area, Harold Wilkie, said when we use diagnoses and labels, it talks about the sin of negative spread. Because one person has one label, then people think they have other disabilities as well. So if you're seeing somebody, you talk to people who use a wheelchair, a number of people will tell you, people come up to them and say, how are you today? And like as if pretend that they can't hear either. Or that some kind of strange behavior means a mental illness when it's something completely different. So this sense of we think things spread. One of the really fun things to get at for you and for your staff and also for the people we might work with is this. Talked about this exercise last night. I love doing this with people. Put I am and then put 10 blanks on a piece of paper. And then put qualities about who you are. Things you like, memberships, things you're part of, faith community, parent roles in your family, job. But you can't use job. At least typical people can't use job in this exercise because we so much base our identity only on our jobs. What do you do? You're in an airplane. Who are you? Where are you from? What do you do? Those are the three questions. But to get at the huge parts of identity that are beyond job, Jewish background. I am Jewish. I am what? I'm Mennonite. I am Methodist. Parts of that for people. Very important. I'm a such and such fan. I love dogs. I'm a grandparent. Let's talk, if I find there are other people here I know are grandparents. So we could start talking grandkids pretty quickly. That would be a connection. And we'd build a way to do that. So helping people to really see in person-centered planning, good person-centered planning, hopefully helps people see. Now, one of the things you can do in faith communities is if you're working with people with intellectual disabilities who are in agencies, they have a right to invite people they want to invite to their annual planning meetings, which means you could be invited if you let them know and say, if you'd like us to come, we'd be glad to come to those meetings. Because if good person-centered planning involves not just staff and family, but friends. And there would be a huge role there of having somebody come and kind of feel like they were with them. This is my church, and let us participate in this and work on the kind of goals and visions that people have. That's a way of doing quiet advocacy relationship to that. Person-centered. For identity, though, and is the who am I question. The other kind of core spiritual questions, we ran at this quickly last night, are the core spiritual questions of what it means to be human, or the who am I, why am I, things we think about early on, and I sometimes say it took me to about age 55 before I stopped worrying about what I was going to do when I grew up, or who I was going to be. The kind of why am I, my sense of vocation. What my wife says is the biblical question, not who are you, but whose are you? Where's our sense of connection and community? Who do you belong to? In the South, we say, who are your people? The kind of thing, who are the people who have got your back? Where's the place you go where they have to take you in, other than DDD, or something which you hope is not. How do I shape my life? What kind of power and control do I have to my decisions will be heard? And why do things happen? How do I deal with those kinds of answers? Well, voila. Those are the core values at the heart of the DD system. The core questions. We just talk about them in different ways. In the DD Act, independence, productivity, inclusion, self-determination, cultural competence. Independence is the American answer to the who are you question. We're supposed to be independent. And independence became the goal, the vision for so much of DD services because for so long people had been treated as too dependent. So we go the other way, completely the other way, to say the goal is to be independent, kind of forgetting about the in-between step about interdependence. But still, that's the value in our country. You're to be self-made person, your own person. You know, I don't need anybody, those kinds of that. So we get to be self-determined, lonely people sometimes. If you take that to its extreme. The productivity question, value, vision for DD services, that gets answered by let's get people a job. But productivity is how do I know I'm making a difference? What am I supposed to do? Am I doing something I enjoy? Is it just a make job, or I'm getting to do something that really fulfills something in me? And that can be through contribution in other ways, not just a job. But the whole job question is still just this huge puzzle that we've worked on supported employment for 30 years. The job percentage needle has not moved that much. But there are ways to find people things to do that mean something to them. It doesn't have to be a job. It can be volunteering. It can be doing other things. And one of the pieces we've got out here, we worked on this project. I told some of you last night, and if you weren't here last night, one of the most fun projects I've had over the last few years is a job called Putting Faith to Work, where we challenge congregations to take one of their magical components, the capacity of a group of people to care around somebody. In the system, we call that a circle of support, and match it with the social capital in congregations. And because all those people in congregations are either employers or employees. And the biggest way we all get jobs is through connections and networking. And try to say, how could congregations help people with disabilities find jobs? By mobilizing the community to find this person a place to do what they would like to do, or try some things out. It's called Putting Faith to Work. We've got a manual out there that comes out of what we learned, and we hope people will take it and make it even better. It's not a franchise operation. It's really putting two ideas together and saying it's not rocket science, but connect these two things and run with it if it looks interesting. Whose am I? Under inclusion, integration, the huge value in DD services. The huge value, inclusion, integration. Whose am I? In our system, we've answered the inclusion question by where rather than who. Where do you live in the community, in a group home or someplace in the community rather than an ICF or an institution? This is where inclusion means in the community. The biggest question is not where people live, but who are you still connected to? What kinds of relationships do you have outside of the staff and your family who are paid to be there? And if you've all ever done the relationship maps that are in person-centered planning, which is, if you don't know what that is from a church, envision a circle in the middle, a person, a number of rings that go out, and the people in their lives at the distance in terms of closeness to that person. And a lot of people with IDD have a few people around the center, mostly family. They have a lot of paid services around the ring, outside, but not very many people in the middle in terms of friendships and acquaintances and community connections or memberships. So, whose? Self-determination. How do I shape my life? I've worked for 10 years on New Jersey's Self-Determination Project, one of the most fun things I ever got to do in the early days before it got bureaucratized. And it really was a chance to say to people, what do you dream? What do you need? And we'll shape what we support, the supports we give you according to your vision and what your level of need is. Part of the reason it got bureaucratized, I think, was that people were having too much fun with it and getting to do some things. And the range of funds that got used got to be too wide for bureaucrats to handle. And some legitimate questions about equity in a system with diminishing resources. Then cultural competence, how do we enable, there's a lot of focus on this in the system these days, how do professionals and service systems respect the culture that people come from with whom they serve. So to respect the culture means they're going to have to respect the religious traditions that are at the heart of those different cultures. If you're serving Jewish clients, people, there's no way you can serve those folks without saying, okay, so what part of you? Are you a Jew in name only, like a lot of Jewish folks, or am I a cultural Jew or a religious Jew, or what branch do I belong to? Same thing with Christians, and same thing with the ways that certain kinds of faith groups are parts of communities and the core of those communities. Those are the core questions. So how do we help them practice what they preach? How do we help systems practice what they preach from those core values? Spirituality, my definition for that is focused around where do people experience a sense of the holy or sacred, what's sacred to you, what are core meanings to you for people, values, and then connection. Connection to self, to others, to holy, to place, to time. We could have a lot of fun with that. Where are your sacred places? What's your sense of connection to ancestors, to future, to present? A variety of ways of looking at that. And I mostly focus on three things in terms of identity: who are you? The question of purpose: why are you? Where do you get what's your sense of hope and vocation? And third is the connection, the community. Those are, I think, are the core. So, from a systems point of view, if I'm a minister going to a group home or to the DD system and saying, why should you do this? And I can't use the argument because religion is important, because that might sound like preaching, and they might throw me out depending upon their experience with faith or people of faith in the past. I would then start saying things like, whatever you think about religion, the power of whatever people consider to be sacred is undeniable in people's lives. Whatever you think, it makes a huge difference for people. It is the way that many people find meaning and how they cope. More people will turn to a faith community or a faith leader before they will go to a psychiatrist, a psychologist, or a service system, or a social worker, or a counselor. If you're going to be culturally competent, you've got to be able to respect that dimension, part of people's lives. If we say we believe in self-determination, then no matter what you may think about the importance of faith involvement, whatever people choose is what you've got to then support in terms of their choices. This is what it doesn't get looked at. The staff who work with you, the direct care staff, how do you deal with, quote, their spirituality? What drives them? What's their sense of vocation? Why do they want to be in this kind of position other than it's the only job they can find, or it's the entry-level position? And for many, there's a sense of calling to that, and a sense of, with all the problems, John and I and you all know, there are just some incredible direct care staff around in people's lives, and just incredible. But they don't get much recognition. I testified at the Texas legislature last week about this thing, the very same thing at an appropriations hearing, and said one of the great ironies and great inequalities of our healthcare system is that the further you get away from the direct hands-on care, the more you get paid. And so part of the question becomes, how do we not only figure out pay? Texas, the rate is like $8.75 an hour, not 11. And they wanted to cut back Medicaid reimbursement rates last year. This is just crazy. And then providers will just go out of business because they can't find people to do that. But how do we deal? You all have all worked for organizations. You know the difference between a healthy and fun and organization, and you know the difference between with one that's sick at its soul, where things are people just not a good, healthy working environment. Business world spends millions of dollars trying to figure out how to do the difference in that. But the key thing, I think, is the basis of Jewish and Christian traditions. We say we want staff to treat people in person-centered ways. Well, then we've got to treat staff in person-centered ways. People give what they get, and unless we do that in that kind of way, and that means all the way up and down, we've got to flatten out provider organizations in ways that people feel like they're working together on a team, and that there's a community in that. And then grief and loss is pervasive in the system of services, of supports, and not just at end-of-life issues. moving issues, moving out of a home, the huge problem of people staying in a family's home until the parent died, all the parents are dead, and all of a sudden that's the only way the person can get services. So you've lost the last parent and lost a home all at the same time. Turnover rate, think about the loss involved in that. You get close to somebody, you lose them, then you've got to learn to trust somebody again. There's just that huge ongoing cycle is just, so it's pervasive. And the system as a whole, we're not very good at talking about grief and loss in the IDD system. Thank God we're finally getting better. But that's one place where you as clergy or congregations or people of faith can really offer something to community organizations and say, look, we know you've got grief and loss issues. We'll be glad to help you with this. Because one of the worst things that I've ever seen, I used to get called in New Jersey to some agencies when somebody died unexpectedly. And I was glad to go, and I've worked a lot in this area and written some about it and some stuff in the book about it. But the thing is, I'm a stranger showing up. We don't call strangers in when we have a lost situation in our life. We call friends. We call the people we know. We call our spiritual authorities or whoever in that. So I'm a stranger. So that's the importance of connection. And you've got to then say who's the most important. And then agencies don't know what to do with it. I did a training on end-of-life issues one time with one agency and some others. We used to do these around New Jersey and had people from the same agency, big agency, who didn't know each other. Some of the people said, we've been told that if there's a loss or a grief, we're not supposed to cry or show any of our feelings, that that's too personal, and we shouldn't do that. And so other people from another group home said, oh, we've been told it's just fine, or that we can do that. So you've got one agency that's got two different kinds of things going on, and there's this whole complexity there about what it means to be professional these days, especially in direct care, and what professional boundaries mean. And one of the ways that I try to get at this in a number of ways, but for me, it most got heightened around end-of-life issues, because if you have, for people who end up at the end of their life and there are no family members really part of their lives, it may be only staff who've been there over time, who's going to tell that person that they've made a difference in their life? Who's going to say something about thank you for who you've been? Who's going to do that kind of blessing to people? And when we say as staff, we can't call you a friend by policy, then what we're doing is taking all the power for defining that relationship and giving it to the professional rather than saying to them, you can call me whatever you like in that sense. We're taking away power while we say at the same one time we're trying to empower people. So the issues are there. And then simply, there are 355,000 organizations of direct, natural, generic supports, otherwise known as congregations in this country. And our system worships direct, natural supports, says that's the most important thing in people's lives. But sometimes people ignore those in terms of thinking about it. Congregations are the most significant source of donations, volunteers, and community leadership in the country. That's what it is. There are people who have written books about that. Think about if an agency decides to start working intensely on helping people be included in communities of their choice. Think about what a powerful public relations initiative that would be when congregations begin to see a mission carrying and working out its mission and caregiving by helping people become parts of the community. Then they become known and their staff become known. Sometimes I think when the first time somebody goes from a group home to a church, it shouldn't have to be the direct support person going with them. It should be the director of the agency coming in with them, and along with a direct care person who's going to be uncertain about this, or at least find a staff person who comes from that religious background so that they know something about what's going on. And then think of the power of congregations as networks around employment and other kinds of sources of support. But professional public policy people, we've been uneasy partners. We live in a country where people say spirituality is private, shouldn't be public. We talk about separation of church and state. Oh, we can't talk about that because of separation of church and state. All of our money comes from Medicaid. We can't talk about that. It's a wrong assumption. You can talk about spirituality. You can't proselytize. So that's just a wrong assumption. It's science versus religion, human service sciences, psychology, social work, other psychiatry, medicine, many of them kind of uncertain about this religious stuff, not sure how to handle it, even though a lot of people who are in those roles might have come out of faith communities as kids, and they're with a sense of vocation and wanting to do something. Too often, faith gets equated with reason. So people with intellectual and developmental disabilities, sometimes people think, caregivers, systems think, well, why would they be interested in church? Because they can't really understand that stuff. Well, church, synagogue is not just about what we believe and what we understand. I mean, if you talk about what we understand in our respective faith communities, what was it, 2 or 3 years ago, there was a poll that 50%, more than 50% of Catholics didn't understand what their doctrine of communion really meant. It was like we don't understand, and it's not belief, it's relationship. It's relationship. We speak different languages of helping that are very different from congregations and faith communities to systems and agencies. People on the secular side will say, nobody ever trained us on this, just like pastors say, nobody ever trained us on this. So, okay, but there are people out there, you just start a conversation, learning from people. And then there's the fear of each other's power and prominence. Systems will say, look at all those churches, oh my God, there's so many brands, how do we relate to them? They all so different. And then the congregations will look at the agency world and say, God, we don't understand their language, what's the structure, who's responsible for what do all these things mean, yada, 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 and all those kinds of things. You guys who are taking pictures of slides, there are PowerPoints here, and there's slides here, so you can get all that. And if you want the PowerPoint itself at some point to take these slides and make them your own, just send me an email later, and we'll help that out. This is not proprietary stuff, and I'm too old to worry about where it goes. And a bunch of it's spelled out more in the book if you want to get at that, to kind of put some, but anyway. And then, of course, bad experiences with one another. Lots of people in the disability world have had terrible experiences with their faith communities, and staff hear about that. And lots of people in the religious world have had terrible experiences with healthcare systems and with other kinds of human service systems in a variety of ways. So there's kind of fear on both sides. Or I heard about, or, not going to give me to see a shrink. All those kinds of things that go on. But so for professional practice in the world of disability, there's some challenges here about how we understand our professional role. How do we learn to separate what is this balance and dance of values and belief from public role? People say professionals should be value-free. Well, no, professionals need to be value-clear. They need to be value-clear. People know where their values are, because that's the way you learn to trust the professionals that you work with. You want to know who they are. What's their character? What's their commitment to? We can't proselytize, and we can keep on emphasizing that, not directly or indirectly. There's this bewildering way of practices, fear of power, and people don't know how to work with each other. Now, take it from a whole other perspective. Look at a lifespan from a system side, and think about where spirituality fits in. At diagnosis, when people get that diagnosis and the impact of that at whatever stage of life that is. Think about we talk about getting kids with disabilities included with other kids as soon as possible. Well, where is that place of inclusions for most kids early on? It's in nurseries, and then in Sunday schools, and then in other kinds of places, and then preschools and daycare centers, many of whom are in congregations. Think about the importance of rites of passage. And we said this last night, but There have been agencies who have worked with congregations to help somebody have a right to have a bar mitzvah, a baptism, or whatever, in ways that really build a whole community for this person, especially if they've never had it. And you're never too old to do that. I had a rabbi who was a friend of mine. I called him my minister. He called me his Rebbe. In New Jersey, he worked with a local institution and get people out to these services, but he found out that many of the older people there had never had bar or bar mitzvah services, and he started having bar or bar mitzvah services for these folks. And the only indication, proof they had to have about they were faithful is whether they wanted to come to synagogue. They didn't have to believe anything or demonstrate, each according to his ability. And I went to a couple of those, and you had extended and distant family, pardon the stereotype, many of them Jewish who were now living in Florida, would come to the bar or bar mitzvah backwards, and were just overwhelmed in those services because they never thought that their son or daughter would be recognized in their community in that way. Because that's a way of saying, you are a member of us. You are a member of us. Adult services, think about the ways that people can transition to employment for young adults, adult services. Think about what happens in congregations. Not only worship, but ongoing learning, socialization, recreation, places to serve, places to do things, places to meet people, places potentially to make friends. An agency in New Jersey said to me once, we take people to this church, but it seems that, or somebody in the church said, that it seems that what they really most enjoy is the coffee hour. I said, there are a whole lot of people in this church who only come for the coffee hour. That's where the community happens, and that's where people get the chance to meet each other. And the community building there is, if you're an agency doing that, how do you get to know, make sure people get to know people's names and not just that group from the group home. So thinking through the steps, there are more, I'm going to go quickly through some of this so we can have some time for some dialogue between us. But you've got to start with the person. Start with agencies where they are and what they say their values are in their mission statements. Independence, productivity, inclusion, that's in every single agency mission statement because it's in the National DD Act. And so it's in there, so you can start with their mission statements about what they do and say, okay, here's a way for you to live, not do our mission, but to live out yours. Let us offer you a way. Start from the top, just like when you start with congregations. You don't need clergy to do it all, but you need them to bless the people doing it in the congregation who feel a call to that. You need to get the blessing of the congregation. You need the blessing of the administration and top folks. How do you start? Start talking to people. Start with a plan. Don't make a plan for people without talking to them. Don't come to a congregation saying, we got a plan for you, without talking with them about, really, you start with a need and ask for help. Here's one of the key professional things I've learned. My definition of a good professional these days is a professional is somebody who knows what they don't know, and then is willing to ask. So if you don't know about how to include people in a faith community, then you go to an agency. We've got a guy who's Presbyterian. He would like to be connected to a church. He grew up in a Presbyterian family. But we don't know how to do that. But we think it's really important to him. Can you help us? We'll help you with all the disability stuff. But we don't know how to do the faith stuff. Can you teach us? Can we do what needs to be done? That's the way you start a dialogue. I've gone to, early in my career, I came to congregations with too many steps already outlined for them to do. And you've got to, again, fit into what they ask for their response and their gifts. Introductions, and move towards a shared sense of responsibility. Try to make sure agencies avoid the thing, and I've heard stories about this, of bringing 4 people in a van and dropping them off at the front door of the church on Sunday morning, and then expect it without having the kind of work being done to be included. spiritual assessments that could become part of assessment and planning process, and there are very simple ways to do that. There are some agencies now who've got really good basic spiritual assessments for the people that they work with. Doesn't have to be complex. The FICA one is very easy. Are you a person of faith? Is it important to you? How does it influence your life? What would you like to do with it? How would you like to do something with community about that? And how can we as a secular professional system assist you? Not how do we provide that, but how can we assist you with that? Other kind of ways. Some more questions to do. These are kind of questions that you can ask people about that. One of the neatest ideas, there's a Jeffrey Coleman wrote a book on grief in adults with intellectual and developmental disabilities. And he had this wonderful concept called, he said, when people come into an agency service, they ought to do with the family what he calls a loss assessment. And what he means by, he talk to the family about when there's been losses in your family, what's your tradition? What part of culture, what kinds of things happen in your family? And at the very beginning of a relationship with a family then, set up expectations to know that then you can say, this is what we do when somebody loses somebody, because if your son or daughter stays with us, some in your family are going to be gone at some point and are going to be lost. And here are our policies about that. We really believe it's important for them to be involved in all of the parts of that life and all the parts of grief. And you think about what the grief and mourning practices are for all of us. It's not really about understanding what death is about. It's all a way of culturally appropriately acting out our grief according to our different traditions. And so many of the actions are physical kinds of actions: visiting, seeing, laughing, eating, going to the graveside, sending flowers, sending a card, all those kinds of components. And if you've been in the system, you know too many stories of families who've said, mom has died and we don't want our son or their son or daughter to come to the funeral, which is just one of the most awful things. This is in the book too. We had a clinical pastoral education student working with an ARC in New Jersey who tried to do kind of like a spiritual assessment for everybody in the agency about what's most important to you. And then they got together and they tied up all the answers and then did a word cloud with it, a Wordle. And if you know Wordle, the more times a particular word is mentioned, the bigger the letters. And this was not so much about, but these were the things that were most important about to people in these conversations. And it was about 70% of those are about things about loss and relationship and what kinds of things happen. And so that's just sort of, those gives you an idea of how that kind of permeates our system. There are good spiritual assessment things that are on here. Support from, we've already talked about that. The Gordian knot that has to be figured out a way to untie is somebody gets connected to a faith community who lives in an agency of some kind, and then the agency says, well, we can't get people there on Sundays because our staffing's worse on Sundays. I'm surprised your figures were so high about I can go where I want to, when I want to go. And because in the national core indicators, there are also correlations between how many times people go to church, satisfaction, number of friends, whether they have a job. There's no causality there. It just means the people who are more involved in their communities are more involved in their communities and connections there. But the Gordian knot is, we have somebody in our congregation who can stop by and pick them up. We'll just do that. That's what we do with everybody else. Well, no, you can't. You've got to go through the vetting process because of liability issues, and to be a volunteer with our agency, it's going to cost this amount of money to get your background check, and you go through this. It's harder in some agencies to become a volunteer than it is a staff member. So that's where the bureaucracy gets in the place of natural supports. And that's where you got to rethink compliant risk planning and think about if a community is vouching for somebody and there's a whole community there, you don't need the kind of legal stuff around that. And then the whole thing about community building. One of the things about working with agencies to help people get to be part of faith communities is it raises all the questions about how do we, on the secular side, help build community with the people we work with. And you build community from the gift side, not from the deficit side, from the interest side, from the passions. You don't build it around their needs or deficits. You got to see the capacity vision. John McKnight says we got to see the strengths in people, the strengths in agencies, the strengths in congregations. Everybody in an agency needs to be a sense of a community connector, not just one or two paid staff people to do the community connecting. It needs to be thought of everybody's job. So if Kathy was a client at my agency and she's Mennonite and she wants to go to church and I'm her direct worker and I'm Catholic and I don't know any Mennonites and I don't know about these strange Mennonites anyway, and I've been told as a Catholic I shouldn't go there, then what I should be able to do is ask up the chain in our agency, say, are there any other Mennonites here who can help figure out how we can get this person to be part of a congregation? And it could be the secretary in the director's office, or it could be somebody else there. So everybody's got the potential. It's using who you know, that 6 degrees of separation. Who do you know? Who knows? Staff roles, introductions are so important. How do you introduce people? Not with labels. John O'Brien says the quality of people's lives is dependent upon the quality of their introductions and their invitations. That's you and me. Kathy and I get in an argument about how I should be introduced. I don't want to be, introductions are important, but I don't want them to be overly important. But the other question is, where do you get invited? And how do you get invited to be things? How do we introduce people in congregations? And people who assist could be known as not aides, but spiritual companions, not volunteers. And the biggest lesson I've learned, and maybe this is where we'll work on stopping. We're not going to get anywhere near this through this for about now, is in community building. This is the biggest lesson I've learned. It took me 20 years. If you look at this thing, I spent in small institutions and agencies trying to get people labeled with disability connected to people in the community. And I worked on this relationship. And to try to do that directly. Would you come meet? Would you volunteer with? Would you do something with us? The trouble is, this direct relationship is fraught with, oh my God, I don't know about those people. I never got any training about that. I'm general public and I hear about special services, so I've got to have some kind of special training to do this. And over here, the people are looking this way and really yearning for connection and friendships, but there's so many kind of emotional, spiritual challenges here of fear, of pity, of other kinds of feelings. And I finally realized with all the people doing good community building stuff is what they were saying is don't go the direct way, go the indirect way. Find out an interest that people share, a passion that they share. Find out where that happens. Find out who's involved. And connect people around that shared passion so that people get to know each other and around a passion. And what happens is that the fact that, and you know that, if you connect with a stranger and you share an interest or a passion, then boom, you're off and running with the conversation. And one of the greatest stories I know about that is Eric Carter, who tells a story about in Madison. He was working with their church, and there were a new group home opened with 4 guys near the church. He went to visit the group said, oh, these 4 guys are all Green Bay Packer fans. They just love to have some buddies with Green Bay Packers. So he put a thing in wrote this nice announcement on a Sunday morning, put it in the bulletin and said, men needed to help get to know some people in a group home. How many walked down the aisle at the end of church? 0. I thought about that for a while and said, well, that didn't work. And then about a month later, they said, we want to start a lot of men enjoy watching the Green Bay Packers and drinking beer. How many people would like to form a church group to watch the Packer games and drink beer? 50 guys came down the aisles. And then Eric says, by the way, there are 4 guys not far from here who drink beer and Green Bay Packers, and they don't ever have anybody to do that with. What happens right there? The tragedy is not the disability. The tragedy is not getting watched the Green Bay Packer games or be within a place where you can drink beer and watch the Green Bay Packers. So facetiously sometimes I say that the challenge here is to change the tragedy. It's not the tragedy, quote, of a disability, because it's not. But change the lack of participation, of being able to do something you really love, into the fact that you can't do that is a tragedy. And somebody who has that same passion and same interest will respond and say, they can't get to do that? Oh my God, that's awful. I'll help them with that. And then they'll help out of their strength. And you can say over here, I'll teach you about the disability stuff, but I don't know Green Bay Packer stuff, or beer, or opera, or fishing, or whatever that interest might be. And that's where you kind of work on building those connections and relationships together. So, there's a lot more here. You have it in those things. A lot of it is in the book. That's not a plea to say go buy the book. But for me, it's been a lifetime of work trying to bridge these worlds and find ways to help people in the service system think about spirituality and the importance of involvement, and get them to do that not because I'm a preacher saying you faithless, bureaucratic, secular, human service system folks, you don't care about religion, but to help them see that there are ways in which they can help work on this in ways that help people with disabilities they support and their families to flourish and to be able to live lives based upon the very kind of values that they have. So let me stop there and let's do some dialogue. Okay, thank you.